seminar. My name's Professor Vanessa McDonald. I work here at HMRI and with the University of Newcastle. I'm a Professor of Nursing in Chronic Disease. I'm an Honorary Clinical Nurse Consultant at the John Hunter Hospital, and I am Co-Director of the Centre of Excellence in Treatable Traits, a new centre which we've recently launched here in Newcastle. So on behalf of everyone at HMRI, I'd like to welcome you to this fourth community forum for 2021. Now, whether that be from the comfort of your own home to the real audience that are here with us this evening, and it's lovely to be talking to people instead of a screen, or from anywhere you may be joining us. It could be waiting for the lunar eclipse. But it's very nice to have you all here. Now, before I begin, I'd like to acknowledge the traditional custodians on the land on which we meet this evening. For here in the room, it's the Awabakal people and the Worimi nations. I pay my sincere respects to the elders, past, present and emerging. I'd also like to acknowledge that today is National Sorry Day. Now, thank you for joining us. We're really excited that this evening we have over 200 people who have registered online, and I'm not sure how many people on the in the auditorium this evening, but it's lovely to be here. And this is the second event that's been held where we've had a live audience this year. It's great to be able to catch up, and for those who are watching it later on Catch Up, we welcome you as well. Now, tonight's community seminar will focus on an area of really high importance, and that's lung health. We're specifically going to be talking about asthma in relation to lung health and putting our research under the microscope here this evening. There's going to be a number of presentations. Firstly, we'll discuss basically what asthma management is and how you should be, what you should be doing in order to have the most optimal management of asthma. We will take a look at the events that have occurred over the last couple of years that have really impacted asthma. Things like the thunderstorm epidemic that occurred in 2016 in Melbourne, followed by the bushfires of the 2019-2020 season, and then of course 2020 we were hit with COVID-19. So we'll have a look at those events and the impacts on asthma, and also importantly talk about resources that are available for people to better manage their asthma when these types of events occur. And then finally we'll have a look at the current approaches as well as where we're planning to do research, at least in the clinical arena, over the next 5 years. So, we've allowed time for questions, so please send them via the question function online to us. We've got a team up the back who will facilitate and ensure that those questions are answered. So without further ado, I would like to start by introducing tonight's speaker. Now, as it occurs, we have had someone who is going to present this evening but now has a respiratory virus. And we know the importance of physical distancing and isolating when viruses are present. So we've had a slight change to our agenda this evening. So instead of Dr. Alex Gordon presenting, Professor Peter Walk will be stepping in for Alex. Peter is also going to present his planned presentation afterwards. Now, Professor Peter Walk is a Senior Staff Specialist at the John Hunter Hospital in the Department of Respiratory and Sleep Medicine. And he's been caring for people with lung diseases like asthma and COPD and cystic fibrosis for around about 30 years. Sorry, Peter. I think I just aged him or made him feel older. But he has a wealth of expertise and knowledge and Many of you may know him from the clinics. He's also a senior researcher here in the VIVA program of Hunter Medical Research Institute. Now, for those that don't know what VIVA is, it stands for Vaccines, Immunology, Infections, Viruses and Asthma. Not too many people know that. But it encompasses the types of work that we do here at HMRI. Peter's going to start by talking to us about what asthma is essentially and how it's best treated. And then he'll continue with his other presentation, which is around the impact of these events that have occurred over the last a few years and how they affect asthma. So welcome, Peter.
Thank you very much, Vanessa, for that introduction. I have to hasten to say that both Vanessa and I have been in this field for about the same period of time. Okay, so thanks everybody for coming, and it really is great having a live audience as well as everybody online. And this has been a very positive thing about the last 12 months, that I think it does open up things that we can reach a very large audience, and it's great having people accessing these things online. But of course, it's nice to have people in person and be able to ask questions as well. So yes, apologies, Alex is not terribly unwell, but under the circumstances we thought it's the right thing for him not to come and share his viruses with us. So I'll give his talk, but he's prepared for us tonight. Okay, so we'll just touch upon asthma and some of the general management skills in asthma. Clearly, I wouldn't have had much to do in the last 30 years if this wasn't a fairly broad and complex topic. So it's obviously something that we're only going to touch upon in the broadest terms, and this may or may not have a lot of direct reference to your individual case if you do have asthma as well. It's very hard to be able to address that in this sort of a forum. But we'll talk about some of the importance, the current guidelines that we have with asthma now, the traditional approach, some newer approaches which have become available, the importance of the evidence that we have now that back up many of the treatments that we have available for asthma, and that's very, very important. In the last 30 years, we've seen a significant improvement in our understanding of asthma and a real improvement in the treatments that are now available for asthma. And most importantly, the treatments that are available for people with the most severe type of asthma as well. So I'll touch upon that at the end. It's not all about medications though, and I do apologise, we probably won't spend as much time as we should on this, but really this is as much about lifestyle and protecting yourself as anything else, as is almost all chronic disease, of course. So, breathing. All right, it's really important that we remember the first step in this is really to have a clear diagnosis that the problem you have is asthma. And your doctor is the best person as your first port of call to go and understand that. There are many symptoms that come and go, and there are many symptoms that people might assume are due to asthma, such as breathlessness, cough, wheeze, those sorts of things, but they aren't always due to asthma. And it's important to clearly know that a diagnosis is present, where it's needed to do appropriate lung function tests and to see that a diagnosis of asthma is actually present. When we diagnose an adult with asthma, we are essentially saying they're going to have a condition that they are likely to need treatment for the rest of their life. This is likely to have significant implications on their day-to-day functioning and even their occupation as well. So it's an important diagnosis to make, and it's an important thing that we make the time and take the effort to go through and ensure that diagnosis is correct. And that is the first step. Unfortunately, relying upon symptoms alone is simply not enough. And so there is a very important component of looking at things like lung function testing and looking at response to therapy and seeing how that evolves over time. Sometimes that is not something that we can make a diagnosis in a 10 to 15 minute consultation, and it may need to take a little bit of time before your doctor is certain as to whether that diagnosis is present. It's really important that people, the majority of people over the age of 12 years and adults, have regular treatment for their asthma. We now know that the safest and most effective therapy for asthma for the majority of people is treatment with a low-dose inhaled corticosteroid preparation. While that may not help your day-to-day symptoms or may not seem to be effective when you first start taking it, and your reliever puffer may relieve those symptoms immediately, it does not treat the underlying asthma. It does not treat the inflammation, which is the background of asthma. And a low dose of an inhaled corticosteroid is by far and away the most important treatment for the majority of people out there with asthma. We recommend the use of relievers, such as your blue inhaler or Ventolin. That is commonly used and has been around for a very long period of time. That can help with your day-to-day symptoms, but it is not a treatment for asthma. It is a treatment to relieve the symptoms of asthma. And if we find that you're using your puffer more than a couple of times a week, then that's a red flag that your asthma is not well controlled, that you need to think about what might be going on here, and you may need additional treatment or assistance. So this is taken from the Asthma Management Handbook, which is the Australian guidelines, more or less, of asthma. It might be a little bit difficult to see, but it basically looks at the patients out there and who should be treated. So we can see here very much down the bottom, very few patients should be out there using just a blue reliever inhaler alone. If you only need to use it once, twice a month, that's possibly okay. But any more than that, you should be receiving treatment, and that treatment needs to include at least a low-dose inhaled corticosteroid. Now, we have two options here. Either you use a low-dose inhaled corticosteroid every day on a regular basis, or it is possible to use a combination of a fast-acting reliever and a low-dose inhaled corticosteroid just on an as-needed basis. So if you have mild asthma, that is the most effective treatment for you. If you still have symptoms, however, you need a little bit more treatment, and we advise you to step up and have either a regular low-dose inhaled steroid plus what we call a long-acting reliever medication in combination. And if you're still having problems, we escalate that to higher doses of inhaled corticosteroids. Some of you probably have more serious asthma than that, and you're more than aware that unfortunately, while this works for about 80% of people out there with asthma, some people continue to have problems, having exacerbations, needing to use medications like oral corticosteroids. And under those circumstances, we'd want someone to consider referring you to a specialist, because there are now very, very effective treatments which do not involve oral corticosteroids but can control your asthma extremely well. So, inhaled corticosteroids are a cornerstone of treatment. In the long run, they do improve symptoms, though not straight away. They mean fewer exacerbations or flares of your asthma, even if you get colds or flus, or even if you get thunderstorm exposure. They do lead to better lung function. They do reduce the risk of serious outcomes with asthma, and this is the single most important intervention that anybody with asthma can have that will reduce your chance of ending up in a hospital emergency room, and sadly, for a small number of people, and probably about 400 every year, this will reduce your risk of dying from asthma. And the key thing is it treats the underlying pathology which is present in asthma that you may not be aware of, you may not feel, but is there all the time. So, using relievers will relieve those symptoms, but may not treat that underlying disease process. And so, we're really emphasising the use of a preventer in order to be used either regularly or on an as-needed basis. It's really important that you know what your treatment is. It's really important that you know how to use your device as well. These devices aren't always the easiest thing to use, and it's very important that somebody explains to you what it is and how to use it, and most importantly, demonstrates how to use it. But people shouldn't feel bad if they're not sure after having used it even for months, because that's fairly common. And having a bit of a refresher course, either from your healthcare provider or going online and having a look at some of the excellent videos that are available, will assist you in using your device correctly. If you're not using your device correctly, you're not getting your treatment as well as what you should be. So the use of puffers and spacers, or the appropriate use of another sort of device like a dry powder inhaler, is the first and the most important way to ensure you're going to get your medication to your lungs. So again, the severity of your asthma will dictate what sort of treatment you should have. This should be in partnership with your healthcare provider, and this is a reflective process. It may change over time. If your treatment is not working, you may need more treatment. Or hey, maybe it's not asthma. You need to think about what's going on there and decide whether you need that next step in treatment. For those people who've got very severe disease, that small number of people, and it may be up to 5 to 10% of people living with asthma, certainly as adults, there are now very effective treatments. So if despite you're using your inhaler regularly, despite that you're still having more than a couple of flares of your asthma where you've needed to use prednisone in the last 12 months, you may well be eligible for one of these new monoclonal therapies. You'll need to see a specialist in order to ensure that you're going to be suitable for this. But these therapies, with incredibly difficult to pronounce names, all can be very effective interventions for the right people with asthma. They reduce your need to use prednisone, they reduce your flares of your asthma, they improve the day-to-day quality of life that you have with asthma, and they mean better overall control. It's important to treat other diseases that might also impact upon your asthma, and we sometimes forget about this, particularly allergic rhinitis or our nasal disease and sinus disease, reflux or heartburn, obstructive sleep apnea, cardiac disease, and sometimes upper airway problems are very, very important, as well as good management of weight and exercise. Everybody out there with asthma should have a written asthma action plan. This tells you how to manage your asthma and what to do with it. This should be individualised for everybody, and everybody should have access to one if they have asthma. So think about things like your diet and asthma. These are important parts that can impact upon it. Regular physical activity will improve outcomes and reduce problems with asthma. Regular vaccination, particularly your influenza vaccination, and now, of course, your COVID-19 vaccine. Optimal self-management is worth thinking about. You have to take your regular treatment on a regular basis. You need to be able to use your puffers correctly. Everybody with asthma should have a written asthma action plan that they develop with their doctor. And you should know about your asthma and understand the processes behind it. So, regular preventers, particularly low-dose inhaled corticosteroids, are the cornerstone of treatment for the majority of people over the age of 12 with asthma. It's important to have good inhaler technique. It is important to develop a good partnership with your healthcare provider, and the centrepiece of that is the development of a written asthma action plan. If you are still having problems, you should seek help and discuss that with your doctor, because there are very good, effective treatments out there. There's some great, useful patient resources out there as well that are available. The Asthma Australia website and the National Asthma Council website have all got freely available resources to do with asthma that people will find very helpful. Oops. And I think I just clicked one by mistake. Okay. All right, so I'm going to not introduce myself again and move into the second part of my talk. All right, so this is all to do with disasters and why we should be worried. And so given that we're still in the midst of a pandemic, you'll forgive me for some dramatic license with this talk, and I often don't get to have much dramatic license with these sorts of talks. So anyway, okay. So I think as a race, we get along very nicely. We have developed a pretty strong society. People can expect now to live into old age. And so I think we've become a little bit complacent that bad things are not going to happen to us, which is probably just as well. We don't want to live our life thinking that something bad is just around the corner. But clearly disasters happen. And the people who are at greatest risk of disasters are those of us at the greatest risk, or those of us who are most vulnerable in our populations. And people with chronic diseases of any sort certainly fit the bill here. So in the 21st century, we are not immune to disasters, and I'll touch upon those at the end of my talk. But let me take you back to the 6th century AD. At that time, the Roman emperor was called Justinian, and he ruled half of the Roman Empire. Now, the other half in the previous 100 years had been lost. But this guy was a bit of a nerd, and he was a little bit of a workaholic as well. And he was determined to regain the glory of the Roman state and to reconquer the western half of the Roman Empire. He was pretty remarkable. He built some pretty remarkable sort of structures which are standing today, and this is Hagia Sophia in Istanbul today. It's still standing, and it's still quite a remarkable building. He had some less than ideal crowd control skills that would make the Burmese junta envious, but he was an effective military leader, and he pretty much got on and reconquered Italy, North Africa, and even parts of Spain. So in 565 AD, things were looking good. He was winning. The Romans looked like they may well regain their entire empire. But then a series of very unfortunate events occurred, and a series of natural disasters all came together. So in 535 AD, little known to Justinian sitting all the way in Europe, there was an eruption of Krakatoa. Now, Krakatoa did erupt in the 19th century, and that's the one that everybody remembers, but it keeps erupting every few hundred years. It's just whether we record it or not is the important thing. This was apparently a very, very large eruption. And this is the description of what happened to the world over the next 6 months by someone living in the Mediterranean. So it must have been such a large eruption that it threw up so much dust and debris into the atmosphere that it actually caused a drop in the temperature of the world in general, the opposite, obviously, of perhaps what we're experiencing now of global warming. That drop in the overall temperature was certainly something that was noticed. That in itself wasn't a problem. But it is presumed that that drop in temperature allowed the migration of these black rats from southern Africa up the Nile Valley and onto ships, and then they arrived in the Mediterranean world. That's not a problem. The rats weren't the issue. It was, of course, the fleas that they were carrying with them. Upon those fleas, they carried Yersinia pestis, which causes, of course, bubonic plague. In 565 AD, there was a major outbreak of bubonic plague, which affected Western and Eastern Europe and caused probably the death of between about 15 to 20% of the urban populations. It was a disaster. Even Justinian got the infection, though he survived. As a consequence of that, it all fell apart. Within 20 years, that whole edifice that he'd created had pretty much collapsed. And with 100 years, the Roman Empire was pretty much limited just to the area around Constantinople, and the Arabs had taken over nearly all of the Middle East, and all of the Western nations and conquests that it had been lost. So it is best not to be too complacent, and it is best for us to remember we are, of course, still inhabiting this planet. So the first thing I want to talk about is more of a slow-burning issue, and that is air pollution. So, not surprisingly, this is a feature of our burgeoning populations. Air pollution is an important, if not one of the most important problems facing us as a species at the moment. And the direct consequence of this excessive air pollution is a significant effect on all of our health. Exposure to air pollution is probably responsible for about 4.2 million deaths between 1990 and 2015, and a significant amount of healthy life lost in that time. And it probably accounts for nearly 10% of global excess mortality. And you can see that this is not evenly distributed. Countries like Australia and Western Europe do fairly well, but unfortunately, the developing world does significantly worse. It's a particular problem for people living with lung disease. It's probably responsible for 1.6 million deaths due to COPD. 500,000 cases of lung cancer in the world are not due to smoking, but are likely to be attributable to air pollution. Prenatal exposure of our children leads to an increased risk of wheeze and the development of asthma in childhood. It also impairs the growth of the lungs of all children, and if you do not attain your normal lung function by the age of 25, that is an independent determinant as to how long you will live. It is also responsible for loss of lung function for those of us in adulthood. And it's not just about polluting factories. Air pollution due to automobile exhaust is probably one of the biggest factors here. This is just a summary of over 27 studies, all of which basically show that the closer you live to a major road or exposure to air pollution from cars, the greater the likelihood you will develop asthma in your childhood. So there are man-made disasters, and then of course there are disasters that are not entirely of our making. Now, Vanessa mentioned the importance of thunderstorm asthma, and I'm sure you all remember the event which occurred in November 2016 in Melbourne. That led to 3,500 emergency department presentations in an afternoon, which is pretty phenomenal, and sadly, of course, the deaths of 10 individuals. So that's quite an event. That is by far and away the largest event that has had a significant clinical effect from a thunderstorm asthma attack. But these events have occurred, of course, and have occurred in Australia beforehand, and locally had occurred in Tamworth in the late 1980s and then in Wagga in the early 1990s. But this is not just limited to thunderstorms. And in fact, if you look closely enough, every year we have little mini thunderstorm asthma events occurring. So for people allergic to grass pollen, we can see their hospitalisations with asthma go up and down throughout the year. This is when children return to school, colds trigger their asthma. The middle of the year, flu, those sorts of illnesses trigger their asthma. But every summer, around October, November, we see a spike in allergies and we see a spike in people's asthma losing control. So every year there's a little mini thunderstorm asthma event. And then, of course, there was the unprecedented smoke-related problems that we had with the bushfires that affected Eastern Australia in 2019-2020 that I'm sure you all remember quite well. So this occurred over a fairly short period of time, but you can see here between October 2019 and February 2020. This is a safe level, or what the national air quality standard should be, and you can see with the bushfire events that occurred on the east coast of Australia, we exceeded those events throughout December and throughout January. And I'm sure you can all remember the condition of the skies at those times. Despite that being a relatively short period of time, this was estimated to have caused an excess of 417 deaths, 1,100 hospital presentations, 2,000 hospital admissions, and 1,900 emergency department presentations. A very significant impact. And then, of course, and finally, that brings us to COVID-19. So this slide was done a week ago. It is already out of date. What can I say? 160 million cases, over 3 million deaths, unprecedented in terms of epidemics. We're probably handling it better than we did in the 6th century, however. Who is at risk of getting COVID-19? Well, very, very clearly, it is age-related, as I'm sure you've seen. And this just describes risk. So a higher number here means a greater risk, in this case, of death from COVID-19. Unfortunately, the older you are, that risk dramatically goes up. Unfortunately also, at least for some of us, if you're a male, that risk also significantly goes up. Weight is a very important determinant, as it is with many respiratory viral infections. Smoking is no good for you. Ethnicity, I think, is a bit of a misnomer. Look down here at deprivation. This is really social deprivation. And I think that there's a very clear effect that, of course, those who are most socially disadvantaged in our society are at greatest risk of dying from COVID-19. And what about other diseases? Well, we'll always think of asthma, and that was clearly a concern at the beginning of a pandemic. But in fact, we have not seen people living with asthma at particularly greater risk of death or serious outcome with COVID-19. And that's been a very interesting finding I'll come back to. Other chronic lung disease, however, that is not the case. And people with COPD or chronic obstructive pulmonary disease, emphysema, interstitial lung disease, bronchiectasis are at greater risk. And why aren't people with asthma at greater risk? Well, this is one of the things we did to amuse ourselves last year when we were in lockdown. And we actually had quite a lot of samples from the lower airways of people with asthma, COPD, and healthy controls sitting in our freezers here. We found out within the first couple of months during the pandemic that the virus got into these cells using a protein called ACE2. And so we went to look thinking that people with asthma would have higher levels of this ACE2 compared to people without asthma. But what we found was, in fact, the opposite, that people with asthma have lower amounts of this receptor in their lower respiratory tract compared to healthy people. This may be a factor that relatively protects people with asthma. And in fact, a treatment trial, which finished halfway through last year and which was done in the United Kingdom, looked to see whether asthma puffers may actually protect you against COVID-19. So this is the use of a puffer called budesonide. It's a low-dose inhaled corticosteroid, and this was given to people without asthma, but soon after they contracted COVID-19 and they were still in the community. The group who received the treatment with budesonide did better than the group who did not receive treatment. They had a faster recovery, 8 days versus 12 days, and they were less likely to end up going to hospital with worsening of their COVID-19. So between that, it may well be influencing the risk of infection, the transmission of infection to the lower respiratory tract, or the inflammatory response. Certainly, if you're using an inhaled corticosteroid and you have asthma, it's very safe in the context of COVID-19. So that ends my dramatic part to the night. We're probably not witnessing the four horsemen of the apocalypse riding across Australia at the moment, but I think that there are some very important lessons that we should learn from history. One of the things I learnt is that Winston Churchill did not say this, and it was this bloke by the name of George Santayana. So those who do not learn from history are doomed to repeat it, and we certainly should take the opportunity from our current disasters, woes and pandemics to take home some messages and learnings. Thank you very much. And it is my great pleasure to hand over to Dr. Vanessa Clark. Vanessa is a postdoctoral researcher here and is the research manager of the Centre of Research Excellence in Treatable Traits. So thank you very much, Vanessa.
Thank you, Peter. Always a very hard act to follow. It is fantastic to see you all here tonight, and for those joining us online, welcome. We hope you're learning something this evening. Now, I'm going to provide a presentation which follows on about Peter's talk about asthmas and disasters and present some resources that we have as part of the Centre of Excellence in Severe Asthma. So if we think about the three main disasters that Peter spoke about, there's a number of impacts related to these disasters that are relevant for asthma, and also a number of considerations as well about what you might be able to do for each of these things. So if we look at bushfire smoke, there's obviously impacts and concerns around air quality, but there's also emotional impacts as well as to how we were all feeling during that time of the heavy smoke. And, you know, there are some things that we can do as well to protect ourselves during the bushfire and heavy smoke. thinking about thunderstorm asthma, who is at risk, how can we reduce this risk, and planning if there's going to be, as Peter said, a mini thunderstorm asthma every year. And finally, of course, COVID-19, which has obviously been with us for the last 18 months. And what are the considerations for asthma? Has it had any impact on accessing ongoing therapies? And does it have any emotional impacts for all of us? So what can you do? So today I'm going to present some resources from the Severe Asthma Toolkit. So this is a freely available resource that was originally developed by clinicians for clinicians. However, this resource is freely available and anybody can jump on and have a look. Thank you. And anybody can jump on and have a look. There's a lot of infographics that we've developed on here that provide a lot of information on a variety of topics. So do jump on and have a look. It is a fantastic resource. So first, thinking about thunderstorm asthma. So who is at risk? So anyone can be affected by thunderstorm asthma, even without an asthma diagnosis. But people most at risk are those who are prescribed, or who are not prescribed, or who are not taking their controller medication, which Peter talked about in his first talk. And the other population at risk are the people with pollen or pollen allergies or grass seed allergies as well, or hay fever. So how can you reduce this risk? So maintaining asthma control with the regular use of your controller therapy, as Peter talked about in his first slide, is extremely important and key to maintaining control. Effective treatment of allergic rhinitis as well, as Peter spoke about in his first talk. Knowing your asthma first aid, so that taps into that knowledge that we were talking about before, in knowing what to do if you do have an asthma attack, which links in very clearly to having an up-to-date written action plan, which includes thunderstorm asthma advice if you are at one of those at-risk populations. So what should you do in a thunderstorm? So always carry your reliever inhaler throughout grass and pollen seasons, very important, and stay indoors with the windows closed during storms or when there's a lot of pollen around if you know that that's a trigger for you. And if you're having symptoms, seek immediate medical care and advice. So thinking back to COVID-19 now, so COVID-19 presented a various amount of problems for all of us, and some of which we still live with now.
I've got a tickle, I'll get rid of it.
That's fair enough. So how do you manage your asthma during these periods of community transmission? So most importantly, continue your maintenance treatment as prescribed. It's very important, don't stop that treatment. And as Peter demonstrated, it's actually quite protective. People with asthma should have an up-to-date written action plan and know when and how to use that action plan. People with asthma who require oral corticosteroids to maintain their disease control should continue to take them, and nobody should be stopping their inhaled asthma medications without first discussing it with their healthcare provider. So is there a greater risk for people with asthma? No. So Peter has established that asthma itself is not an increased risk factor for increasing the likelihood of getting COVID-19. So should you isolate? So we do recommend that people with severe asthma isolate when there's active community transmission, but severe asthma is a very complicated disease. It's often associated with many comorbidities as well. So thinking about COVID-19 and asthma a little bit more, there were changes that were needed in the way that care was delivered during the pandemic. So one of the biggest ones that we all would have noticed is the use of telehealth. So suddenly you could see your GP over the phone, your GP might have even FaceTimed you, which was fantastic. There were also changes to the way some people received their monoclonal antibody therapies. So people with severe asthma who are on these therapies were able to start injecting them at home, not having to go to a clinic to receive that, and increase the chances of getting exposed to any viruses that may have been in the community at that time. So there's also considerations for COVID-19 vaccines and those who are taking these monoclonal antibody therapies. And the Centre of Excellence in Severe Asthma recommends that MAB therapies, monoclonal antibody therapy, should not be administered on the same day as the COVID vaccine. The reason for that is in case there's any adverse reactions, we can tell what's causing those adverse reactions and then treat appropriately. Also, the initiation of new monoclonal antibody therapies should be avoided for 14 days after the COVID vaccine. And again, it comes back to that understanding what is causing what if there happens to be any problems. Are there any changes I need to make in the way I take my medication? So probably one of the most important ones for people with asthma is the use of nebulizers. So using nebulizer therapy can make a virus, if you have a virus, into an airborne contagion instead of a touch surface contagion. So we do recommend the use of a puffer and a spacer, which is equally as effective compared to a nebulizer when there's active community transmission of COVID-19 or if you have COVID-19. So I'll move on to bushfires now. So this is a graph that was taken from a survey that Asthma Australia completed looking at the impact of the smoke in people with asthma, which is the blue bars here, compared to people without asthma, which is the orange bars. And down the bottom there is just the percent of people who reported these symptoms. So as you can see, people with asthma had reported an increase in respiratory symptoms. Over 90% of people with asthma reported those during that heavy smoke period. People with asthma also reported reduced capacity for daily activities during these periods of heavy smoke, and they also reported that they stayed inside with their doors and windows shut. So it was an impactful problem for people with asthma and of course everybody during those periods of heavy smoke. But what can we do about it? So what should people do in times of heavy smoke? So avoid the smoke is the best bit of advice. So reduce outdoor exposure and activity. Stay in your house, close the doors and windows. Put the air conditioner, if you have one, on the reverse cycle so it's just cleaning the air on the inside for you. Avoid other sources of indoor air pollution like candles, wood fire, incense burning, and work from home where possible, again using telehealth. And partake in indoor exercise during periods of heavy smoke. And we had a participant recently say that they were walking around the shopping centres to get their exercise because the air was more controlled there. Should people with asthma wear a mask? So Asthma Australia don't support or don't advocate for mask wearing for people with asthma because in times of heavy smoke, because it creates a false sense of security in that people might stay out in the smoke exposure for much longer than they need to be. However, if you do go out into the smoke, what you need to wear is a P2 N95 rated face mask that is properly fitted to filter out the particles that cause the problems from bushfire smoke. It's important to note that the cloth masks and the surgical masks that we've been using throughout COVID are not good enough to get rid of the smoke particles. And of course, it's really important to monitor your local air quality data, and there's a myriad of apps that can do that for you to help you plan your day. So the bushfire asthma checklist is another thing that you can use to plan, and it's important that it's got 6 steps here. So the first step, I'll quickly run through it, is that have a bushfire plan. You can get those from the RFS, so that's really important to get yourself out of harm's way if you need to be. The second one, have an up-to-date written action plan, which we've spoken about a lot. The third one is have a medication plan, so ensure your asthma medications are in date, have a 30-day supply in case of shortages, and know how to communicate your medication requirements if you need them to volunteers. Keep your medications in a central place so they're easy to grab when you're on the move very quickly. Have an asthma companion who's a person who knows what medications you need and when you need them, and they can tell somebody else if you're not in a position to do so. And try and minimise your stress during an evacuation, it's obviously a very stressful time and that's impossible to do so, but having a plan and easy access to your medication just takes the stress out of that. So the final point I'll touch on is disasters and wellbeing. So these disasters can have immense impacts on our mental health, and it is really important to consider our mental health in these times. So there's a few key tips that we can have, and obviously we have these infographics here that have it in a nice snapshot for you. But access to reliable information from credible sources is essential, and avoiding excessive media intake so you're not bombarded with those negative messages that can really impact your mental health. Maintaining a healthy diet and exercise where possible, and it's very important to seek professional mental health support if you need it. Thank you, and there is the Severe Asthma Toolkit link for you as well. It is now my pleasure to reintroduce Professor Vanessa McDonald to give you our last presentation.
Thank you very much, Vanessa. So I've been tasked to have a think about what we're presently doing in terms of asthma research and where we're headed into the future. So Peter's taken us on a nice journey through history. And now I'm going to talk about the present and where we're headed within our research here at the Hunter Medical Research Institute. And we do a lot of research here into asthma and into lung diseases in lots of different types of research and different research paradigms, looking at basic science or discovery science, where we do animal research, right through to implementing new knowledge into practice. I'm not going to talk about all of those things this evening. I'm just going to focus on one area, and that is around how we can better manage asthma through our approaches or models of care in what we do. So why do we think that we need a new approach to managing asthma? So I think to think about the future, we need to look at the past. And this is a graph of asthma mortality or asthma death rates from the 1960s through to 2012. And what you can see from this graph is that there was a nice decline in the number of asthma deaths that occurred, and we've made really substantial gains in asthma management over that last 30 years while Peter and I have been working in asthma. But what's important to highlight here is that from about 2006, there has really not been an appreciable improvement in asthma mortality rates. So we've not necessarily increased, but there's been a stagnation. And deaths still occur from asthma, and we want that to change. So that's one reason why we need to look at what we've done in the past and how we can improve things going into the future. Another reason we need a new approach is this quote. This is a quote from a person with asthma just recently, maybe a couple of weeks ago. She said, "Our asthma is individual. There are so many different kinds out there, and we all feel different things." And as researchers, we describe this as asthma heterogeneity. So this is where not all asthma is the same. Asthma doesn't affect everybody in the same way. There are lots of different subtypes of asthma, which we now really need to focus on tailoring our approaches to those subtypes. So what is the solution to this problem? You may have heard of precision, personalised or targeted medicine. This is something that's been used in a number of different disease areas, in cancer, in cystic fibrosis, now in asthma. And if you think about, well, what is precision or personalised medicine? It has been defined as an approach where treatments are targeted to needs of individual patients. But they're targeted to the needs of patients on the basis of genetics, on biomarkers, phenotypic or psychosocial characteristics that distinguish any given patient. So these things might be molecular targets, they might be inflammatory targets, they might be clinical phenotypic targets, or mental health, as Vanessa was mentioning earlier. So how can we take this personalised or precision medicine and apply it in asthma? I'm going to give some examples. First, I'd just like to think about how we used to traditionally think about asthma. And if we use these little people to represent that, you can see that there's a few people here and they're all the same. And that's how we used to think about asthma in the past. We then started to understand through research and improved knowledge that people are different. They might have different inflammatory phenotypes in relation to their asthma. This person might have an eosinophilic pattern of inflammation. This person might have a neutrophilic pattern. This person might have both. So we thought, well, let's treat people in these subtypes or these phenotypes where we cluster all the people with that type of inflammation and this type of inflammation, and we treat people like that. But then we further expanded our knowledge and started to think about things differently and think, well, if we do things like that, there's going to be all these other things that are unaddressed. So then we realised that asthma really looks more like this. People in fashionable frocks of different colours. And all these different colours represents different types of characteristics that we see in individuals. So how are we going to apply this new approach in asthma? We're looking at treatable traits. What is this alliteration that I speak of? So this is an approach that we've been working on for some time now, and we started looking at older people with asthma. And when I say older people, this was when I was doing my PhD and I was much younger. And we classified older people as those over 55. I'm starting to rethink that. But we understood that as you got older, things appeared differently. So we did some research to look at multidimensional assessment to understand all of those characteristics of people with asthma. And then we applied individualised therapies according to those traits or those characteristics. Other people started thinking about this in the same way at the same time. And later, the term was coined treatable traits, which looks at individual characteristics or traits relating to asthma and chronic obstructive pulmonary disease, and then applies precision or personalised medicine to treat each of those traits. So if I talk about treatable traits briefly, I'll just summarise it by saying it's an approach that allows us to address the heterogeneity or the differences that we see in individuals with asthma and with COPD. One way to apply this is to do multidimensional assessment that deconstructs the airway disease, whether that be asthma or COPD, into traits, and then applies individualised management. What is a trait? There are many. Some publications that talk about this approach list over 30 different traits. And in order to be considered a trait, we think that they need to be clinically relevant, identifiable and measurable, and of course, treatable. There may be traits that are present in individuals where we don't have evidence-based treatments to apply to those, and that's an area that we're really focusing on in the Centre of Excellence in Asthma Treatable Traits. Traits will fall into 3 different categories. There's the pulmonary traits, extrapulmonary, and behavioural and risk factors. And I'm going to not talk too much about that because I realise that we're running out of time. But do these traits matter? And I just show these graphs here because these are people that we recruited who underwent this multidimensional assessment to see how many traits existed in people that we recruited from the clinics at John Hunter, those that were already being seen in specialist care. And we found that they had a mean or an average of 10 problems that weren't treated, that we could actually target with this approach. And that was the same for a severe asthma population. And when we looked at whether or not they related to quality of life, and this is a quality of life measure with a high score indicating worse quality of life, we found that the more traits people had, the worse quality of life they had, and that for every additional trait we identified, those people had a clinically significant decrement or impairment to their quality of life on this score that we measured. So how can we apply this to asthma, and does it make a difference? So we have tested this approach in randomised controlled trials, and this is one that we did in a severe asthma population where people underwent the intervention, and then we compared that to the usual care severe asthma clinic. This is a summary of the types of interventions that people underwent as part of this. As I said, there are those domains, pulmonary, extrapulmonary, and here I've broken down the risk factors and behaviours into the 2 different colours. These are all the types of treatments that we gave to people. We only gave these treatments to individuals where that trait was present. So we didn't apply a blanket approach of management to everyone with asthma. We supported this approach through assessment, the use of biomarkers, targeted therapies, and facilitated with a case manager to help the individuals apply the therapies accordingly and to provide education that they required. And we improved quality of life significantly doing this approach, both before and after treatment, but also the between group difference of the intervention group and the usual care. And this was a large improvement in quality of life when you compare that to other studies. But if we look at this a different way and think, well, how many people got a clinically significant improvement in quality of life in the usual care group? It was only about a fifth. Whereas in the personalised treatment, treatable trait approach, it was over half. So this is an area that we're continuing to work on. This is an approach that we can apply and we want to be able to implement into the clinic. We know that it improves quality of life, and we know that it improves other areas like acute attacks at the presentation to the primary care doctor for acute attacks, as well as improvements in inflammatory biomarkers. And we see this as our new paradigm for this 21st century. In addition to working on implementing approaches like this, there are other traits that don't necessarily have a solid evidence base in order to inform treatment. There's a number of different treatment populations that we'll be working in. That smaller population of people with severe asthma, a difficult to treat asthma population, moderate, and asthma in pregnancy. And we're also going to be looking at these other things that complicate the management of asthma, like vocal cord dysfunction, physical activity, and side effects of treatments from things like oral corticosteroids and some longer-term antibiotic medicines that we're using to treat some of those types of asthma. So I will end there, and I will just put up some further resources and our social media presence up here for this centre. What I would like to do now is invite the panel up here for a couple of questions. We have some online questions or audience participation in questions. We are a little bit behind time, but we'll see how we go in answering any questions that people have. Do we have any online questions?
Yes, we've got a few questions. So the first one is Kate from Facebook has asked whether you can talk about any new information regarding vaping and the effects of that.
Don't. So vaping's a fairly difficult area and there's not a lot known. It's certainly very much evolving, I think, at the moment. It's complex because the devices that people use and the substances they use in those devices are really quite different, and the potential effects that they may have on the lungs are also really quite varied and different as well. So it's really an area that's evolving at the moment. Before COVID, it was very clear that a small number of people in the United States were getting a very, very serious lung condition called pneumonitis, which was a direct result of vaping, and that led to serious harms. There was a small number of people, but they were young and otherwise healthy. We do not know the long-term health risks of vaping. The medication or the substances themselves and the types of agents that are being used certainly have the potential to cause very serious toxicity, but whether they will lead to the same sorts of problems, even be it at a lower rate than, say, cigarette smoking, with lung cancer and the development of chronic lung disease, is unknown. And that will take years of exposure before we know whether that's the case. it is very hard to see why any medical professional would recommend that it should be used. And while it may be relatively safer than smoking cigarettes, it certainly is not safer than not inhaling something in your lungs.
Are there any questions from the audience?
I have a question. How do the inhaled corticosteroids work? What are they targeting?
So the final presentation that I gave, I very briefly talked about different inflammatory phenotypes or subgroups. So the inhaled corticosteroids are targeting one of those inflammatory cells, and that's called an eosinophil. So they reduce the inflammation in the airway that's caused by eosinophilic airway inflammation. But we know that not everyone has eosinophilic airway inflammation. However, we also know from studies that inhaled corticosteroids are the best approach for managing most types of asthma that Peter spoke about in that first presentation.
And probably a large majority of people will get some benefit from that, particularly people with allergy or these types of inflammation that Vanessa mentioned, eosinophilic inflammation. But for almost the majority of people, a low dose of inhaled corticosteroid is more than sufficient to control their asthma and control their asthma well. And you often don't get much more benefit by escalating those doses to very, very high levels. And you have to start thinking of other things that may be going on or other ways of approaching the problems with their asthma. And that's where the traits side of things starts to come in.
We have another question up the back.
This is another one from Facebook, from Mark. He's asking, for those of us diagnosed with COPD, whether they should go and have their COVID-19 vaccinations ASAP. Even if they've already experienced blood clots in the lungs.
So yes, there is, for those people over the age of 50, it's recommended that they have the AstraZeneca vaccine, which is an effective and safe vaccine to be used against COVID-19. It substantially reduces the risk of severe illness due to COVID-19. A previous history of having clots in the lung or clots in the leg will not put you at greater risk of developing clots related to the COVID-19 vaccine, the AstraZeneca vaccine. Now, the AstraZeneca vaccine has been associated with very rare cases of this clotting disorder. It probably occurs around about 6 times out of every 1 million vaccinations that are given. It's a little bit more likely if you are under the age of 50, and for that reason the Australian government is recommending that people under the age of 50 be vaccinated with one of the RNA vaccines, which is the Pfizer vaccine currently. So the risk is very low. Unless you have had heparin-induced thrombosis or phospholipid syndrome, you are not at greater risk than anybody else. Previous histories of pulmonary emboli, DVT or thrombosis does not put you at greater risk of getting the thrombosis related to the COVID vaccine.
Any other questions?
I have a question.
Yeah.
If you were working to develop a plan and you're working with other allied health professionals, so say like an exercise physiologist, physiotherapist, people like that, are there exercises that you would sort of steer more towards or away from, or how would you go about sort of coordinating the exercise, a physical plan for somebody who does suffer asthma?
That's a great question. And I think the answer probably might be different for the different severities of asthma as well. So exercise is an important part of asthma management. And as is physical activity, which are two different constructs really. One is around making sure you get enough steps in your day, whereas the other might be around moderate to vigorous exercise, etc. So if your asthma is well controlled, you should be able to do and it's mild to moderate, you should be able to do most forms of exercise. Preventing exercise-induced asthma is important, and that occurs in around 80% of people who have asthma. And you might prevent that by doing some warm-ups before you exercise, by pre-medicating with a reliever medication, by not necessarily breathing in cold air, so maybe using a scarf on a wintry morning whilst you're walking. But most types of exercise for people with mild to moderate asthma, when their asthma is under control, are safe and effective. They might say that, you know, swimming is a good exercise for asthma, but others might be triggered by chlorine, etc. So it really does have to suit everyone's individual asthma. And in terms of severe disease, like we're currently investigating different types of exercise that people with more severe asthma might be able to participate in, because if you've got severe disease and your asthma is easily triggered by exercise, you might need to do a certain type. And we recently did a study of yoga here at HMRI in a severe asthma population, and we compared that to an intervention which was having a pedometer, or a Fitbit rather, and some motivational counselling in terms of improving physical activities. And both of those interventions had an effect. They had an effect on different types of things, interestingly. So yeah, I think tailoring exercise to the needs of the individual is probably the best way to go about that. Sam.
So yeah, another one from Facebook. This one from Karen. I think this refers to Professor Walk's talk, where he talked about asthma, people with asthma being a bit less at risk of COVID. What if you have COPD and asthma? What are the risks then?
Yeah, but it's a good question. It's difficult to get that sort of detail and granularity from the evidence which is out there. Overall, people that identified as having COPD were probably at greater risk, whereas the group with asthma, and it's a very broad group as you've heard, and a pretty heterogeneous group of individuals, overall seem to be less at risk. Now, there may well be groups of people with asthma, though, who that doesn't apply to, and we suspect people with severe disease are not so well protected. And similarly, if people have got significant lung disease and significant what we call fixed airflow obstruction, that probably puts them at greater risk of at least getting severely ill as a consequence of COVID, where it may not be at greater risk of going on and getting the infection, but the consequences of that infection are likely to be more severe, depending upon how badly affected they are by their lung disease in the first place.
Can I ask about chronic cough, laryngeal sensitivity, the ways to relieve that, and perhaps also the role of very moderate amounts of caffeine and alcohol in the diet?
Good questions. So there are many causes of cough, and this concept of cough hypersensitivity is one that's evolving at the moment. And that can occur for several reasons, from a central driver for cough to cough in your upper airway to cough in your lower airways as well. And if we think about asthma, poor control of asthmatic inflammation can increase the risk of cough occurring, and that's often controlled by using inhaled corticosteroids. But that's not the case for everybody. And some people have persistent cough and persistent cough sensitivity. Some of that may sit in their middle airway, and that's where laryngeal hypersensitivity and all of its complexities come into it. It could sit in their upper airway if they've got untreated allergic rhinitis or sinusitis. We don't have very good treatments for cough. We have some physical therapies that our speech therapists and physiotherapists sometimes could do that suppress some of those findings. There are some emerging therapies that look at cough sensitivity. and they are promising, but they probably have to be targeted to the type of cough sensitivity that the person has. So somebody who has a lung disease like pulmonary fibrosis won't respond to some of these new agents, whereas somebody with laryngeal hypersensitivity and chronic cough will respond to these new agents. So there are some emerging treatments, but I think cough and the problems related to cough has a very long way to go in terms of treatment.
Yes, Sam.
So this one's from Tanya, and she says that she had pneumonia 11 years ago and is wondering if it is true that your lungs are forever damaged after experiencing that.
Well, it would depend upon the severity of the infection. And pneumonia can be a very serious illness, and it can, even in young and previously healthy people, can be both fatal or can lead to chronic lung disease. And that's particularly a risk in the very young and the very old. For the vast majority of people who get pneumonia, however, they make a complete recovery and don't have any significant or meaningful damage to their lungs that will limit them in life. So it may take some time for them to recover.
And this one's from Janine. How common is it for children to grow out of asthma?
So that's an interesting question, and one that is still evolving in our understanding, I guess. So children will present with wheezy-like illnesses very, very frequently in their life, and that is particularly the case in young children, particularly children under the age of 6 years. Now, only a proportion of them will go on and have persistent cough, wheeze and breathlessness over the age of 6 years. Some of those children no longer have those events, and they're usually triggered by virus infections. If you have a family history of asthma, if you have allergy, if you have persistent episodes of wheezy-like illnesses with colds and flus, and those symptoms persist at the age of 6 years, unfortunately your risk of having asthma or having to live with asthma increases. By the time you're 12, if you still have cough, wheeze, breathlessness, either with exercise or with colds and flus, unfortunately you're likely to continue to have asthma. It is possible for adults, however, also to develop asthma, even if they had no problems in childhood. And some of those people who had wheezy illnesses early in life may well have a recurrence of their symptoms later in life and go on to develop asthma as well.
Okay, I think we might need to end things there. We have gone a little over time, so thank you for everyone hanging in there. I'd like to take the time to thank Vanessa and Peter for their presentations this evening and generously sharing their time with us and to have the discussions we've had and the presentations that we've had. I'd also like to take the opportunity to thank the HMRI marketing team, in particular Seb and Sam, for their organisation of this evening's event. I'd like to give a plug to the next community forum, which is Brothers, Fathers and Sons. So looking at men's health. So there'll be a similar forum but focused on men's health, and that's coming up on the 30th of June. So anyone interested in that, please join us on that evening. And finally, I'd like to thank everybody for coming, for joining in online and being part of this seminar or forum. I'd like to thank you all for the support of HMRI in your engagement in research and in your support of our research in any other way that you may have been part of that. It's really important that we're here at HMRI to develop new knowledge in many different research programs and research areas. And all the support that we can get from the community is really gratefully received. We hope that you have a better understanding of the management and different aspects of asthma management and lung health in general, and that we've been able to provide you with some useful information to help you look after your own health. So thanks for being part of that, and thank you for your ongoing support, and we look forward to catching up with you sometime in the future.